good morning and good afternoon and good evening to everyone, and thank you very much for taking the time to join us at today's launch event. Just for the first couple of minutes, I will go through a couple of technical points in a moment, a brief recap of the agenda. I'll then spend a minute setting the context, and then I will hand over to Nicola Bedlington, who will take us through the first panel. So I'm going to share my screen, so hopefully you can see this. As we've said, as you joined the meeting, and as probably most of you are familiar with nowadays, your videos are automatically off and your microphones are automatically muted, but you should be able to see us as speakers and panelists, and hopefully you can also hear me at the moment, and of course you'll hear the speakers too. We encourage you throughout the next 90 minutes to ask questions and to make comments, and please put those into the chat. They will be picked up by the panel chairs and fed into the discussion at the appropriate points. We're not going to respond to the chat in written form during the presentations, and that's so that we can all focus on the verbal part of the dialogue. Any questions or comments in the chat that remain unanswered at the end of the discussion, we will follow up electronically with you with those responses. The meetings will be recorded, or the meeting will be recorded, and that's so, of course, those that can't join us today, so that they can watch that afterwards. In terms of the format, as you might have seen in our pre-communication, the speakers will each give 3-minute verbal remarks. We're not going to use slides, and once we've heard the remarks from each speaker, we will then open up for the questions and discussion moderated by the panel chairs. And as I mentioned a few moments ago, we would just ask that you put your questions into the chat throughout the discussion, and we'll pick those up. In terms of the agenda, I'm sure most of you have seen this, so I'll just highlight it at a high level. We'll have the brief introduction, which we're doing now. Then we'll look at the vision and framework of person-centered value-based healthcare led by Nicola. Then the implementation and recommendations component chaired by Anne. And then right at the end, just some brief perspectives on moving forward. So just from in terms of the context, I think the focus of our discussion today, and indeed at our earlier launch event on Tuesday of this week, we think is on really one of the fundamental questions that faces us in the design, delivery, and measurement of healthcare. And that is, how do we balance a focus on the individual while at the same time ensuring effective quality improvement and benchmarking at the level of the service or pathway, while at the same time balancing the need for the equitable allocation of resource at the level of the overall population. And we know, of course, that many of you joining our event today have thought about these issues extensively, and indeed are leaders yourselves in this area. And so we hope over the course of the next 90 minutes that the discussion we have can contribute to us collectively advancing our thinking in these areas. Indeed, it is our view, I think, that there is an opportunity to bring closer together the concepts and paradigms of person-centered healthcare, value-based healthcare, and population equity. Just a couple of acknowledgements that we wanted to make. And for those of you that have had the chance to read the report in the methodology section, we were able to bring together a community of experts, many of whom are speaking today and were speaking on Tuesday. Without this collaboration and the contribution of time and expertise, we certainly wouldn't be discussing this report today. So I think our sincere thanks to the speakers and the community of experts for the work that they've done with us all in producing this report. Similarly, we were able to form an industry advisory panel with contributions from a variety of pharmaceutical and medical technology companies, And again, without that input and expertise, I think our discussion today would be poor. So our thanks also to those companies and individuals. And finally, our sponsors who gave financial contributions and in-kind contributions to help make this work possible. And they included the Leiden University Medical Center in the Netherlands, the Institute for Evidence-Based Health at the University of Lisbon in Portugal, the European Federation of Pharmaceutical Industries and Associations in Brussels, and finally, the Health Standards Organization and Accreditation Canada in Canada. So I'm now going to hand over to Nicola Bedlington, and just a brief introduction to Nicola. Nicola is the founding partner at Millwater Partners, which is a consultancy focused on sustainability, and she takes particular responsibility for health, social policy, and multi-stakeholder engagement. And probably what Nicola is most known for, at least over the past 15 years or so, is the significant development of the European Patients Forum in Brussels into a very influential organization. So I will hand over to Nicola. Thanks.
Thank you very much, Tom. Thank you for that very kind introduction, and a warm welcome also from my side. I've been delighted to co-chair this project together with Dr. Sally Lewis, and I'm very pleased to have the privilege also to moderate the first panel discussion today. The report is clearly a culmination of much reflection from a broad range of experts worldwide, and I personally have learned a great deal whilst hopefully bringing in a patient advocacy and European perspective. And I've seen over the last 18 months how complementary our collective efforts are with existing sister initiatives in the person-centered healthcare and value-based healthcare space. And I believe that these synergies will really help us move forward on our vision for person-centered value-based healthcare. And this brings us nicely to the panel of today, where we'll be exploring with 4 panelists the vision and the framework for person-centered value-based healthcare. And I'd like to introduce our first panelist, who is Angie Hamson. And Angie is a patient partner lead at the Health Standards Organization in Canada, supporting patient partnership in the development of healthcare standards and also in the context of accreditation. Angie is also a patient and caregiver herself. You're very welcome. Thank you for joining us today. And I'm really looking forward to what I will imagine be a patient perspective. Please, the floor is yours, Angie.
Thank you, Nicola. Thank you so much, and to Thomas as well for inviting me here today. It's been a pleasure working with you all over the last year. Today, knowing that today here in Canada, it is the National Day of Truth and Reconciliation. So I just wanted to start out by acknowledging that I have the privilege to live, work, and play on the traditional and unceded territories of the Algonquin Anishinaabe, Haudenosaunee, Mohawk, and St. Lawrence Iroquois peoples. They've been living on this land for millennia, and we acknowledge the past and present contributions to this land. Thank you so much for that, for giving me the time to do that. As Nicola mentioned, I am a patient, but I'm also a caregiver. I am a parent of a child with a complex medical history. So we've been in and out of the healthcare system for 12 years. And we've seen things that have gone really, really, really well. And we've identified some gaps, let's put it politely, and I've had a chance to see where we can do better as a healthcare system. What is high quality care? What is healthcare, right? When you're looking at how to deliver high quality healthcare, you've got a myriad of information, sources of information, from test results, from patient histories. And I think it's really important that we look at the patient's perspective and look at things through the lens of the patient, who is at the center of care. A clinician comes in at a specific moment and sees a snapshot in time, but doesn't necessarily see the context of where this situation or this healthcare concern lies in the patient's life. When we're looking at developing treatment plans and goals of treatment, are we looking at reduction in a mass size or stabilization of certain levels or reduction in infection? Or are we looking at the resumption of activities and the reduction in regaining function and quality of life, right? So how is it that we're judging what matters to the patient? I want to tell you a little bit about my dad, if you don't mind. My dad was fighting cancer many years ago, and unfortunately, his treatments only worked for so long, and he became terminal. So at that point, his treatments became less about survival and more about comfort. And I was actually due to get married that spring. And so for my dad, his big priority was making it to my wedding. So he ended up in the hospital in that January. So we moved our wedding from the spring to early February and hoped it was in time. Now, his whole medical team knew his goal was to walk me down the aisle. And so they moved heaven and earth to give him as many treatments as they could. They drained his leg, they wrapped his leg, they rewrapped his leg. They did everything they could to make him as mobile as possible. And on that February morning or afternoon, he walked me down the aisle. He was able to dance at my wedding. He actually even stood up on a chair to give a speech, thanking everyone for coming. A week later, he was in a wheelchair, right? All of those extra treatments bought him the independence that he wanted to be able to be an active participant in my wedding. He even had a suit made. He even had a suit made to accommodate his swollen leg. That was how important it was to have that moment of normalcy in the midst of all of these cancer treatments. As I said, 1 week after my wedding, he was in a wheelchair. 10 weeks after the wedding, he died, peacefully surrounded by family members. His goal was never going to be survival anymore once he was palliative. His goal was to walk me down the aisle. His goal was to have the quality of life with his family. And that's what I think sometimes is missing. When we measure outcomes of care and goals of care, are we measuring the things that matter to the people that are at the center of care? Are we looking beyond simply health, hospital readmissions and central line infections? Are we looking at the things that actually matter to the people at the center of care? That's what person-centered value-based healthcare looks at. What is it? How do we get as close to achieving the goals of the people that are at the center of care? For my dad, it was about controlling pain, yeah, sure, but it was also about maintaining that independence. And he achieved that goal. And he was very happy to be able to do that. Thank you very much.
Thank you very much, Angie, also for sharing a very personal and poignant story that demonstrates absolutely goal-oriented care and why that matters so much. We'll come back to you, obviously, for the panel debate, but thank you very much for that. I'd now like to move on to our second panelist, Adam Wolf. Since 2012, Adam has been the CEO of the Danish Regions in Denmark. Danish Regions runs all public hospitals, 97% of all hospital activity, and contracts with general practitioners and healthcare practitioners. So Adam, you're warmly welcomed here. Thank you very much for joining us. And I'd love to hear your perspective. I guess it's going to be a health systems perspective. The floor is yours.
Thank you very much, Nicola, and thank you also to Angie for an excellent presentation of what is most important in person-centered and value-based healthcare. It's obviously the patient perspective, the citizen perspective on what is important to the individual. I will speak more to the aggregate level, the system and the hospital level, and recognizing that all different health systems have different structures, different finance models, private, public ownership, different levels of standardization or use of technology, so that this perspective will always be interpreted in different ways in different historical and national contexts. But still, if we want to strengthen the patient perspective and the person-centered and value-based healthcare perspective, we also need to design healthcare systems, to design processes, structures, even decisions on procurement and prioritization from the perspective of the patient. So we need to aggregate the data that we get on the individual level, and that's not an easy task. As you all know, it's much easier to measure output than outcome. It's much easier to measure at the hospital level than it is at the national or healthcare system level. So it is challenging, but it's nonetheless the perspective we want to integrate into goal setting and into the way we develop our healthcare systems. Resources are limited in any healthcare system, and the focus on what matters to the patient is also a help to make us choose wisely at the system level. It means that we should learn from all the multitudes of individual goals and preferences, and we should learn from the patient perspective what procedures, what processes, what structures helps give the patient influence not only on the individual pathway, but also on how the system is organized and how the system meets the patient in terms of communication, integration of the needs of the patient. I think what no healthcare system does this perfectly at the moment, obviously not. But this is the person-centered and value-based healthcare perspective is, in my view, first and foremost, also a language that makes it possible for us to learn from each other, to learn between hospitals, between healthcare systems, and learn from some common standards of what is important in our healthcare. Also, how we allocate resources in a way that is equitable and brings the patient perspective in the forefront also in macro decisions. So this would be my introduction. Thank you, Nicola.
Thank you very much, Adam. And we'll again come back to you to delve into a little bit more depth some of the points that you made. Airton Stein, a warm welcome to you, Atten. Atten is productivity scholar at the Brazilian Research Council, and he is currently an internationalization advisor and professor of public health at the Federal University of Health Science of Porto Alegre in Brazil. So another continent, another perspective, and I know that you're passionate about looking at low and middle income countries when it comes to patient-centered value-based healthcare. So really curious about your thoughts today. Please, you're very welcome, and the floor is yours.
Thank you. Thank you, Nicola, and I'm grateful to be part of this team, which was very rewarding in every sense. The vision of person-centered value-based healthcare is that we are able to work towards achieving the goals of individuals, linking the goals to standardized outcomes and ensuring the equitable allocation of population budgets. Low and middle income countries are in a unique position to incorporate the principles of this proposal as they further develop their universal health care systems. The context in low and middle income countries after COVID-19 pandemic, as we know, has led to health inequality, especially on digital health. As a result, we know more than ever need to ensure that we fully focus on understanding the goals of individuals and linking these to the outcomes we capture. We must also ensure people are involved in pathways, design, and decisions around resource allocation, and that patient advocacy groups are involved in policy formation. This will help to ensure that we truly focus on achieving the highest value, which has to be the right approach, particularly given the very limited resources available. Education of healthcare professionals on the principles of person-centered value-based healthcare as there is a need to move away from a paternalistic model to a model focused on this strategy. If this is to be successful, then we have to have the support of healthcare professionals. We see it is an opportunity for them to really partner with their patients. Finally, capturing standardized data, for example, through successfully using patient-reported outcome measures, can be achieved through the use of mobile phones, as this device has a significant potential in supporting this approach in low and middle income countries. Thank you.
Thank you very much, Atten. And this echoes very much the input from Nicole on Tuesday at the other launch meeting. She was talking about the situation in Africa and made a very similar remark with regard to access to mobile phones. So interesting. Thank you. And again, we'll come back to you in a few minutes. Our last speaker is Antonio Vazquez, who is from Portugal. And Antonio is full professor at the Faculty of Medicine at the University of Lisbon, where he directs the Centre of Evidence-Based Medicine, the Institute of Preventive Medicines and Public Health, and the Institute for Environmental Health, and finally, the Institute for Higher Education. So research, I think, is your thing, and looking forward to hearing from you, Antonio. We can't see you or hear you at the moment, Antonio.
All right. Now
perfect.
Okay. Thank
Terrific.
you very much, Nicola, for that introduction. I'd like to thank you and Tom for this wonderful experience for our last year. My idea here was basically to raise 3 specific points on our proposal for a person-centered value-based healthcare. This is a huge area. It's a very complex area. And maybe I just pick up 3 issues that I thought were very interesting to discuss with you guys. And I will pick up exactly where Ayrton left with the outcome measurements or the problems. We need definitely a way to standardize outcome measurements, because the aim is really a systematic collection of real-world data that can meaningfully inform all these systems. Okay? So they should be simple and meaningful for the individuals and for the professionals. But there is a tension here, because in its current form, standardization means that structures, processes, and outcomes that we captured will not always reflect what matters to the person individually. So there's a work to be done there, and we recommend that at this point in time, what we should do is maybe to use some of the systems that already exist to overcome this problem, and we're suggesting ICHOM and PROMISE. So we need to standardize the outcomes, but we realize that at the individual level, it's somewhat difficult to have a clear view of what the specific person wants. Now, the second point I would like to raise is the diminishing resource overuse. As I'm sure you're fully aware, there is this area of too much medicine, in which most of us believe that at a certain level of care, we are just doing too much. And there are a whole bunch of initiatives like choosing wisely, less is more, sustainable healthcare at Cochrane, etc., that try to diminish the overuse, the resource overuse. And we believe that in this system that we are actually proposing, this is a very central thing, because we have a lot of tools that we can use to diminish too much medicine, too much interventions, like de-diagnosing, de-implementation, de-prescribing, whatever. But in this system that we actually want to implement a value-based, this should be a central issue. At this point in practice, we believe that this is a really important issue. And certainly there are already a lot of movement, a lot of excellent research around the world defining precisely this. Finally, and very quickly, just to finish, we need to train the healthcare professionals. We need to train the healthcare professionals. And from that point of view, we need to train them in 3 major areas. Be able to practice shared decision-making, to be able to have a goal setting which is of high quality, and finally to be able to have a outcomes measurement as an important issue in the practice. Okay, we believe that this should be done in universities, employers, postgraduate centers, doesn't matter. But we have to make sure that the healthcare professionals accept the coordinated and integration of care. Okay, and so they probably should also be involved in designing the information pathways and the system that we are defending. Okay, so they can look at all this in a holistic view. So these were just 3 specific points that I wanted to raise in this extraordinary new movements that we are taking forward, especially in a post-pandemic era in which the challenges will be higher than ever. So thank you very much.
Thank you, Antonio, and it's great to give the context of our post-pandemic era. Could I have the videos of all of the panelists on again so we can see your faces, so we can kick off the discussion a little bit? We've had one question so far from the chat, pointing out that each citizen has different views on the outcomes that matter to them, and how would we manage that at both organizational and at systems level? Who would like to respond to that question? So I'll pick on Antonio, actually, if that's okay.
I can't see the question. I'm sorry, I apologize.
Okay, I think Adam wanted to, I'll repeat it in a second, but I think Adam wanted to say something initially. The question is...
yeah, sorry. Yeah.
The question just is, each citizen has different views on the outcomes that matter to them. How can we actually manage that effectively at organizational and at systems level?
Well, as I said, I think it's a very good question. It's a very difficult question to resolve. But I think one of the recommendations in the report is that we should try to move some of the time spent with patients, between patient and healthcare professionals, move it to the beginning of the patient pathway, so that we make sure that we actually have the input from patients. We have the possibility of co-decision on different ways of planning the trajectory. So this is obviously something that each healthcare professional, as Antonio also indicated, should be good at, should learn. But at the systems level, we should also allow for planning in a way that gives the opportunity to have the thorough dialogue. I know in any case, in any health system, resources are limited and it's very difficult to give that priority, but there's a lot of indication that we will save time, we'll save waste, we'll save unnecessary procedures and unnecessary worries for the patient if we give it more time in the beginning.
Great, thank you. Would any of the panelists like to add to that, or do we move on to the next question? Any further thoughts on that? Okay, please, Atten.
Yes, I'd like to just add to what Adam has said, that patient engagement towards a culture of patient-centered health value is essential. So every health professional and even these every stakeholder should be involved in this engagement to change the culture mindset. That's what is on the report, bringing this all together.
Great, thank you. Let's move on to another question then. I think there's been a comment that actually healthcare professionals should not only be educated, but actually perhaps patients and citizens could also be educated, because they will be they need to move from actually confronting a paternalistic approach where they're pure recipients of care to actually engaging and participating. And Angie, I'd love you to answer that in a second, but another question's come on about educating systems leaders to adopt this approach. And you talked, Adam, about learning health systems. So I'll come on to you in a second to get some reflections of that. Angie, please, what are your thoughts about educating, supporting, training, building the capacity of patients?
I think that's a great point. I think it's really important to be able to develop that capacity in patients, but I think we also need to recognize that there's going to be different levels of activation. And so there are some people who want to be much more in control of their own patient experience and journey. And there are some people that are less comfortable with that. So I don't think we want to force anyone to be in more of a leadership role in their own care experience. If they're more comfortable saying, I trust the clinicians, I trust my care team, and I really want their perspective on what I should do, as opposed to sort of saying, I want the information and then I will make an informed decision. I think we need to meet people where they're at and help bring them along in the journey to provide that education and training so that they are aware of their options and how involved they can be in this.
Great, thank you. And to you, Adam, health systems leaders and the kind of training and capacity that they may need to have, again, thinking about your comment on learning health systems.
Well, I think it's definitely not an easy task, but I think that the advantage we have is that healthcare professionals and health system leaders are all into data. Typically, it's been classical clinical data, but we have seen some very, I would say, touching and radical shifts in clinicians' perspectives when we started using PROMs and PREMs. The realization for a medical doctor that has worked for many years with his patients, for instance, in diabetes, that suddenly it's not only the clinical data like blood sugar levels, etc., but it's also perhaps the wife of the patient saying, well, the real problem he has is that he can't sleep at night. To hear experienced clinicians reflect on how wrong they had been on what mattered to the patient. Not that the clinical data are not very important, obviously, but the perspective of the patient really touches healthcare professionals and system leaders, I would say. It should do so. So I'm optimistic that if we use PROMs and PREMs, if we get the feedback of the patients to system leaders, we will actually direct our attention to those needs.
Great, thank you, Adam. We have another question that highlights, are there today enough operators capable of using the tools of value-based healthcare? And I'd like to invite Antonio to comment on that, because I know you have a couple of thoughts on how you would want to perhaps restructure health systems for person-centered value-based healthcare. Any thoughts on that, Antonio?
Thank you. Well, I think Adam already said that the basis for this entire endeavor is information. And the scientific information, clinical information, patient information, management information, we need information. The big challenge here is how to make that transfer of the information to the right targets. How do I present the possibilities for a patient to choose or to tell me exactly what their priorities are? We think that there has to be an investment from the side of the system, hospitals, health centers, primary care health centers, in order to capture at every single day a certain amount of data in which the PROMs and PREMs should be there, and so that we can analyze that on a regular basis and then give feedback not only to the professionals but also to the patients in terms of trying to figure out where are we heading. Is this the right way to get there? And at the same time, are we comfortable that we are actually working in a very transparent and explicit environment in which all the decisions are duly justified? And I think this is a complex approach. I believe that's going to be the future. I have no doubt in my mind about that. And at this point in time, we are still building them up. And what we are doing is choosing some hospitals and some medical centers and choose one disease and work in that. And that may be the beginning of kind of scaling up the entire system. But it will need investment. It will need a lot of time of people looking at this.
Great, thank you, Antonio. We've had a question come in that is focused broadly on the whole area of patient advocacy and the role of patient organizations. Atten, you were very clear that patient advocacy groups need to be involved in policy formation. Can you give us any examples of what's happening in Brazil on that front? That's really interesting.
Well, I'm involved in planetary health movements, and I see that the grassroots are taking place and trying to identify how to help out what is being called as co-benefit, the benefit of the patients themselves, but also the benefit of the planet, to have a more broad view of public health. In fact, we have been trained as public health professionals just to identify indicators for a local community. But nowadays, the local community is the planet. In fact, we have to try to develop strategies to improve the health of individuals, but also the health of the planet. And there are several examples that local communities are trying to improve. For instance, in near my city, there is a plan to have a coal mine that is due to open, but there is a big people's movement trying to persuade the authorities and the public opinion to persuade not to have this coal mine, which is 13 kilometers from the center of a big city. And of course, especially in a recession, people try to see it as a good investment, but not in a long term. And in fact, this is the kind of thing that we need to persuade people to have a new cultural mindset.
Sure, and that points to sustainability in all its guises. And in fact, if you look at the sustainability goals, how interrelated all of those goals are, goal 3 on health and the other goals looking at environmental sustainability, an excellent point. Angie, could I move to you very quickly? I think it's been demonstrated also in the chat that in a way, patients' goals are non-linear and they may shift in time as a patient lives with a chronic disease or acquires another chronic disease, multimorbidities and so on. How should the individual, how should the healthcare professional in dialogue, in trusted shared decision-making best manage that? And how could perhaps the health system, be that at local level or more broadly, build that into the equation? I know it's a complex question, but I'd be really interested on your thoughts on that.
I don't know if I can come up with all of the answers. If I could, we wouldn't be here if we could solve it in one shot. I think, from my perspective, looking at that regular communication, and like Antonio was talking about, it's about information. And I would go one further and say it's about the communication. So how do we communicate those changing goals, the changing needs, the changing perspectives as we go through care? It's not just a matter of having a case conference at the beginning or a goal setting session at the beginning of treatment and then pursuing treatment unchanged for years or for a disease course. I think we need to have those regular touch points to say, how are things going? How are you doing? Is this working? When there are significant changes, we should be having those touch points anyway. But having that regular communication, and I think part of that is about having clinicians that having a reliable team, having care delivered by professionals that you have that trusting relationship with, not just, when you have people that are still seeking family doctors who are going to clinics that don't have a physician that is monitoring their care on a longer term. I think you have much more disjointed care. I think when we have people that have complex issues, that have professionals from multiple jurisdictions or multiple disciplines, I think we lose some of that. When the right hand doesn't know what the left hand is doing, we lose a lot of that as well. So I think when we have cohesive, unified care that everyone on the team knows what's going on, we can have much more of a seamless delivery, and we can better achieve our outcomes and our goals. I think at a systems level, looking or at an organizational level, having that type of organization where the teams are talking, that's really important. Because I think if so often I've called my son's my son's had a number of surgeries and seen dozens of clinics, and I've put a call into the neurosurgery clinic when they talk about doing surgery, and I've asked them if his heart can take it, and the clerk on the other end of the phone says, "Oh, he has a heart condition too," and he'd had 2 open heart surgeries already. Mm-hmm. So for me to say the neurosurgery clinic doesn't know that the cardiology clinic has been involved, and the reality was the surgeons knew, the doctors knew, the clerk didn't. Yeah. But it undermines the faith that I have in that clinic.
Sure.
So
good. I think the point is very clear. In fact, in the chat, there's also the proposal of a sort of liaison to act as a pivotal point to help that communication optimize. I'm seeing Tom, but I would just like to give each of the other panelists perhaps 30 seconds to sum up with one final thought before we move on to Tom to introduce the next panel. Antonio, 30 seconds, final thought.
Thank you. Well, I would say again, I'll try to go back to the Angie, what Angie just said, and stress the information, the area of information, of high quality clinical and practical information. Without that, we'll not be able to actually work properly. Patients should be able to comprehend all the sides of the treatment, not only when they show us what they want, but then the choice should be very well, really. So there's a big, huge effort we should do on translating all that knowledge into a way that patient can understand and actually act upon it.
Clear, very clear message. Thank you, Antonio. Adam, over to you. Last 30 seconds. Elevator pitch.
Yeah, I think we should also just touch briefly on financing, because many people say this will be very expensive, but our experience, at least in Denmark, is that if you ask patients whether they would have a surgical procedure for the knee or the shoulder, or they would have training, they would very often, and they have full information on pros and cons, there will be more people choosing training. The same for end-of-life care. We overuse our resources in end-of-life care, and it's not always what the patient wants. So, indeed. Sorry. Thank you.
Thank you very much, Adam. Really important points. And last but not least, the Atten, last 30 seconds before Tom gets cross with me.
Thank you, Nicola. I was just wondering to state what is on the report, what are the implications for implementation, and it requires we reflect on core conditions and constraints and search for facilitators and enablers. And the last but not the least, low and middle income countries may need special attention.
Absolutely, absolutely. So thanks to all 4 of you. I think this has been a really interesting panel. It's helped to set the scene for the next panel. I'd like to give the floor to Tom to introduce that panel, and Anna, our moderator. Thank you all very, very much, and enjoy the rest of the session.
Thank you, Nicola. Thanks a lot. Great. And just one thing to think about as we go into the next one, which I know will be picked up, and I see Sean entered a comment in the chat, how we can link the goals to the standardized outcomes that we capture, rather than just expecting everybody to align with standardized outcomes. And from a population perspective, once decisions have been taken around resource allocation, how we ensure that teams are empowered to effectively use that allocated resource to meet the goals and therefore outcomes and desired processes of the individual. So with that, let me introduce Anne Stiglbout. Anne is a professor of medical decision-making at the Leiden University Medical Center in the Netherlands, with a particular focus on shared decision-making, risk communication, clinimetrics and psychometrics. And Anne's published very widely in this area, with, I think, a particular mention of a landmark paper in the BMJ in 2012 around shared decision making. So we're delighted you've been part of this, of course, Anne, and that you're chairing this session. So over to you.
Thank you very much, Thomas, and thank you, Nicola, and the previous panel. I thought that was a really exciting panel, and there were so many questions in the chat that we could just fill our 3/4 of an hour with answering all those questions, but we'll likely get even more when our panel starts. I was contacted by Thomas and Sally exactly at the time when I had a PhD student, Marta Kidana Mariam, who was on the Tuesday panel, thinking about how patient-centered is value-based healthcare. And then out of the blue, there came Thomas, Sally, and Nicola. And we joined forces, and it's been a wonderful endeavor. And you've seen the report, or you've had a chance to see the report. And hopefully seeing this whole chat exploding, we'll continue together in this endeavor, because we don't have all the answers to all your questions. We need them also from you. And today we're getting a few more, I hope, from my panel, and I would like to start immediately with introducing Bruno Brown. I'll pronounce it in the Dutch way. Bruno is a Dutch politician of the People's Party for Democracy and Freedom, the VVD, and he served as Minister for Medical Care and Sports from 2017 to 2020. And he's mostly going to speak from the healthcare system perspective, I assume. The floor is yours, Bruno.
And good afternoon. Thank you for your kind introduction. I feel a little bit shy because I feel surrounded by all very experienced healthcare professionals, which I'm not. When I started as a minister, I had a background as a lawyer and not as a medical professional. And what I learned many things in the period that I was a minister, and one of them is the importance of shared decision making. Shared decision making between the doctor and the patient. And when I learned about the topic, I thought maybe there are many steps already set and done. Isn't it a work in place already system that there is a kind of shared decision making applicable for each patient? And I think in the past years, some steps were made. But when you start to think about the shared decision-making subject, the first thing came to my head, which is a tremendous problem to get all the validated and standardized data available from the one hand side, on the professional side. And on the other hand, you need patients who are willing to participate and to understand. When I was a patient and I went to the doctor, then I would sit on a chair and ask the doctor, well, doctor, tell me what is best for me. So only one solution from the doctor would be the perfect one. But when I learned about shared decision making, you can better understand that there are different patients and they have a different treatment or a different cure. So for this, the validated data is very important. And the question could be how to start and where to start. Maybe this is not only a national subject, but it is, I think, an international subject. Some of the knowledge I got from the Department of Health in the Netherlands, and some of the knowledge and some of the expertise I learned in sessions that were in the World Economic Forum in Davos, where I had the chance to meet with Michael Porter and also with Stefan Larsson. And Stefan Larsson, I remember one of the sessions, he said, let's not only do the talking, but maybe we just start collecting data, start the discussions, start making first steps. And even when IT solutions are not at hand, are not available yet, then we take a pen and a pencil and just make the first steps. And I found that a very, very practical remark, and I love that. And this is the reason that I like to follow the subject of shared decision making, not only as a minister, but as a simple, modest, and a little bit shy citizen. And I hope I will never be a patient which needs to have some practice experience with shared decision making, but then let's do it for the society. This is 3 minutes on, I guess.
Thank you very much, Bruno. Thanks very much for your points. I immediately hand the floor to Sean. Sean Tunis is a senior fellow at Tufts Center for Evaluation of Value and Risk in Health. And until recently, he was a senior advisor in the Office of the Principal Deputy Commissioner at the FDA in the USA. Sean, the floor is yours.
Yeah, thank you, Anne. I am going to be talking mostly from the perspective of health technology assessment for these initial comments. And I've recently been the president of Health Technology Assessment International. I want to try to quickly get into this tension that a number of the questioners and commenters have raised about this tension between population level decision making and the individual decisions through shared decision making and other approaches. So as most of you know, health technology assessment is fundamentally a tool of optimizing the use of resources at the population level. So in some senses, you could say it's in conflict or tension with the decisions of individual people and patients. You know, what's been interesting over the last decade, say, is from work by some of the folks who are on this call, Karen Facey and Carolyn Turwey and others, a recognition that in health technology assessment, which analyzes clinical studies of medical technologies, drugs and devices, there has been limited engagement from the patient advocacy community and the patients, and particularly around defining which are the outcomes that actually matter most, and to make sure that those are the ones that are emphasized both in clinical research to generate evidence, but also in the assessment of studies that are done. And a couple of folks have mentioned things like that, you know, the outcomes that matter most to patients may not in fact be the ones that are included in clinical trials or emphasized in value assessment. And so there actually has been some progress, some considerable progress in both engaging patients in the regulatory processes and reimbursement processes, even clinical trial design, to focus more on patient-centered outcomes. And by patient-centered outcomes, I mean the outcomes that you learn from patients and their families are the ones that matter most. And kind of here's the key, which is if you don't actually include the outcomes that matter most to patients in the clinical studies of health technologies, there's no way that those can be looked at in terms of value assessment, health technology assessment, and therefore these resource allocation decisions. And so kind of the first kind of key, I think, on the path towards person-centered, patient-centered decision-making is to make sure that the outcomes that matter most to people are actually included in clinical research. There's an organization many of you may be familiar with called the COMET Initiative. It means Core Outcome Measures in Effectiveness Trials. And the basic idea there is work with clinicians, work with patients and other stakeholders to define a limited set of the most important outcomes and make sure that those are consistently reported, measured and reported in all clinical studies in a particular therapeutic area. So for example, if it's diabetes and patients are less concerned perhaps about their hemoglobin A1C, but they're very concerned about hypoglycemic episodes, you got to make sure that everybody who's studying a drug for diabetes is reporting that. And I realize I'm running out of time, but I like to use this analogy, and some of you may be familiar with Consumer Reports magazines or magazines that evaluate different consumer products like washing machines. And they identify, well, what are the most important things about washing machines that consumers care about? It's how noisy they are, how clean they get the clothes, how efficient they are with the water. And then every washing machine is then measured in terms of how well it achieves those objectives. And then individuals can decide, well, which aspect of the washing machine is most important for me to make my own decision. Like I want an energy efficient one, or I want to one that uses the least water, or, you know, so, but again, unless those are measured for every option, there's no way that you can get to individualized person-centered decisions. So I'll stop there.
Thank you, Sean. Looking forward to hearing from the audience about this analogy. We'll get that later, I guess. I'll continue immediately with the next panelist, Willem-Jan Bos, colleague of mine in the Netherlands. Willem-Jan is an internist specialized in kidney disease, and he's on the value-based healthcare steering group at Leiden University Medical Center. And he's one of the co-chairs of the Linnean Initiative, and that's a national initiative in the Netherlands in which patients, physicians, and administrators collaborate to facilitate the use of outcomes of care in the office. Willem-Jan, the floor is yours.
Thank you, Anna, for your introduction, and thank you all the attendees for their presence. My focus will be in the office and the interaction between a patient and the healthcare professional. And it has been mentioned in some of the remarks that it is the quality of this interaction which really counts, and we want to improve that quality. And I think we could come from two perspectives. As Anne told, my prime perspective, where I come from, is the value-based healthcare perspective. And value-based healthcare, of course, strives at optimal outcomes of care, both for individuals and at group level. But if you look at the implementation, and especially when benchmarking is involved, we tend to focus on optimal outcomes at group level. And of course, there are initiatives, especially, I think, even more so in the Netherlands, where shared decision-making is an important issue in the movement of value-based healthcare. But nevertheless, you see, once you start benchmarking, you focus on the group outcomes. And as anybody has either been a patient or a professional knows, individual preferences might be at odds with optimal outcomes at group level. And I think that's where person-centered comes in. Person-centered care does not involve the systematic monitoring and improving of outcomes, but it focuses on the individual preferences. And what we try to do in the report we've written on person-centered value-based healthcare is that we try to combine the best of those two worlds. And what does it mean? It means at an individual level that we should try to get a grip on what really matters to patients. And of course, we should always do that in discussion, but we also learned very much from the prompts that have been mentioned in the questions and in the chat quite a lot already. And I know very experienced colleagues who were stunned when lots of their patients started filling out prompts, and they told, well, finally, after 20, 25 years in practice, I start seeing what bothers most of my patients, and I know what to focus on in the next consultation. So I think the prompts are not only outcomes, they're kind of inputs as well for your next conversation. And of course, we should register not only the prompts, but also these individual goals. And it has been mentioned that will be difficult and we will have to group them, but we should start noting them and we should start categorizing them. And that's the difficult task we'll have at the meso level, at hospital levels, or when we aggregate outcomes and aggregate practices for a specific disease, either regionally, nationally, and start, if we want to compare it, we should use those goals in order to relate the outcomes which we achieve to the goals set by the individual patients. And that will be quite a challenge, but I think, as Bruno said, we should simply start doing that and mentioning what the aim was for a specific patient. Was it to live as long as possible? In my case, treat patients, elderly patients with hemodialysis, or have the discussion whether a patient wants to forego this rather burdensome treatment. And if you have this discussion properly, quite some patients want to forego it. And once we start comparing survival, just survival, we should know who made an individual choice not to undergo an intensive treatment. Thank you for your attention.
Thank you, Willem-Jan. And we should start, but maybe not with pencil and paper, like Bruno said. We have other means nowadays. I'd like to give the final panelist the floor now, Thomas Alvin. He's currently the Executive Director of Strategy and Healthcare Systems at FPA, the European Federation of Pharmaceutical Industries and Associations. He previously worked as Health Counselor for Sweden to the European Union, and prior to that, he worked for the Swedish Ministry of Health. So we have a Nordic perspective here as well. Thank you, Thomas.
Thank you so much, Anne, and thanks everyone for a great discussion. And it's truly been a pleasure to be involved in this important report, and I'm very excited to be part of the launch. And then hopefully, of course, after launch comes the real work when we actually need to implement all this, and that's certainly what this panel is about. So just make a few points from the perspective of sort of life science industry, and maybe specifically the pharmaceutical industry, as I come from in FPA, and just to say that I think that the road towards both value-based healthcare and person-centered healthcare for the industry should start and needs to start really at the beginning of R&D. So it's not something you can start thinking about once you already have a product. And I think that more and more pharma companies and certainly medical devices companies are doing this more and more to involve patients already during the first phases of research and development, and working more and more actively with patient engagement to really understand what are the patient needs, and what are the metrics which should look like, and how do we design products and services for those needs. And for instance, so FPA published a few years ago a paper on working together with patient groups to really explain why patient engagement is necessary throughout the life cycle of a medicine, and many FPA members have been involved in the so-called Paradigm project from the Innovative Medicines Initiative to develop a toolbox for patient engagement throughout the life cycle. So this is certainly coming more and more, and I think also data shows that more and more submissions to HTA agencies, to go back to what Sean was talking about, contain patient-reported outcomes and such data. Of course, it can always be better, but I think the trajectory is certainly there. And I think also of course it all goes both ways, and I think that for the industry it's important also that then HTA agencies and payers also value and recognize these different outcomes or patient satisfaction, and because it's really the signals also needs to go back the other way, and sometimes if the industry get the signal that these things are not always valued by HTA agencies or payers, then the signal back to the industry would be that, well, it's don't put money into, don't invest into R&D into these things. So this is why it's so important that all the actors in the system sing from the same hymn sheet, so to speak, and have the same view and alignment, which I think why this report is so important. Just finally a few words on of course on the kind of payment model side, which you also mentioned in the paper, and the industry is certainly engaging with payers and new types of payment models to try to tie the payment to outcomes, to make sure that the reimbursement is tied to actual outcomes achieved. And I think there is a lot of work on this. I think more collaboration is needed here to kind of facilitate the use of these models and overcome hurdles. They can be legal, technical. A lot is about the data collection, and we need to make sure that the same data can be collected for all these different use cases. So healthcare professionals and patients and others don't have to collect the same data all over and over again. And I think that the end result here, we're moving into a new kind of paradigm where the industry is more invested in the outcomes for patients, and thereby get invested into adherence, etc. And I think that's ultimately a good thing, but it will require much more closer collaboration between all the actors in the system. Thank you.
Thanks, Thomas. Yeah, we have lots of work to be done, and it's good to have all these people here in the community and have the people in the chat. Hopefully they'll stay as involved as they are now. You mentioned HTA and researchers looking more at the outcomes that matter to patients. There was a first comment from one of the patients in the chat, Hans Bart, from the Dutch Patient Society, also reinforcing that nowadays, due to better patient involvement in research and in problems measurement, that the topics that maybe before weren't so sexy to researchers are studied now because they are more important to patients, and that's really important. A few questions for Sean. Maybe one to start with is that health tech, Catherine Mitchell, forms part of the patient pathway and should support the reimagining of care. Can you see, Sean, how the whole care trajectory identifies outcomes that are relevant to patients?
Yeah, it's a great question, and I haven't given it a lot of thought, but I just my kind of initial, off the cuff view is that perhaps some of the models that are now used in the context of medical technologies, drugs and devices, like the regulatory agencies convene meetings, patient-focused drug development in the US. I'm not sure what the EMA version of that is, where the meetings are mostly composed of patients with a particular condition who can comment in detail about the actual experience with care and treatments and what outcomes matter. And I don't see why that model couldn't be expanded beyond just a focus on the drug or device intervention or the diagnostic to the entire care pathway. And similarly, the kind of focus group methods and Delphi techniques that are used in developing the core outcome sets for specific interventions, I think those methodologies could also be applied more broadly across the care pathway. So my thought is that the methodologies for gaining insights from patients and clinicians would be equally applicable across the care pathway if that was simply the scope of those reviews.
Thomas, you were nodding. Are you in agreement with Sean?
Well, yes, absolutely, and I think that also we're moving towards. We see more and more of kind of combination products and devices. So maybe you have a pill, but you also have a diagnostic, and you have a digital device, and you see more and more of these integrated products. And I think we also need to get better at sort of measuring the overall outcomes and value of those products throughout the patient pathway. So absolutely.
Thank you. On a different slant, there was a question on shared decision making, maybe for Bruno or Willem-Jan. Do you see a role how to support that with ICT or IT?
Maybe I can start off telling about our Santiam Experiments, where we do devise patient decision aids and try to personalize them and feed the decision aid with outcome data. Easiest on survival. We're also trying to use quality of life data, and a patient could fill out his age, and we could give personalized or age dependent prognosis with different treatments. And of course, you still need the individual conversation with your physician who knows about your comorbidity and further topics important for you. So that has to be personalized even further. And I think another example is from the field of diabetes, where we used a newer technology with continuous glucose monitoring, where you get a lot of feedback, which can really help patients to understand what's happening. And I always give the example of my own mobile phone. and see where you count the number of steps you've taken during the day. You can see exactly where I started looking. Once I had the feedback, I realized I had to do more. So I strongly believe in feedback from the data we have.
Bruno, do you want to speak to that as well, or maybe add, because the last in the comment in the chat also concerns shared decision making, so maybe you can also.
Yeah, maybe one remark to add.
Yeah.
I told you I am a lawyer by profession, and in my study I learned that the citizen is that was called a one-shooter, and the government is a repeat player. So the government is always working on, let's say, the system, and sometimes the citizens needs to have something from the system. Maybe you can translate this one shooter and repeat player to the subject that we are talking about. When you become a patient, you are in the system and it's all new for you. And you see hospitals, doctors, GPs, and to create to pose the best questions to your doctors is not that easy, and you are maybe a little bit modest or a little bit reluctant to ask your questions, and maybe you do not understand all the answers that are given to you. So what could be helpful, I think, is that we put patient groups in a strong position to make sure that somebody in the place of the individual patient takes care of helping this discussion a step further, making to understand, to pose the good questions, and that you get answers that you, as a, let's say, a citizen, you can understand well, and that not always the same question for every patient is the same answer applicable.
Yeah, you make Hans Bart happy now, because he commented that patient organizations need to be supported to play their role in this task, because I think it's not an easy task. In the previous panel also we talked about educating patients. I mean, we have to educate both patients and clinicians to make this reality, because we're still far from it yet, I think, even in the Netherlands, where shared decision making is quite on the forefront, I think. A question was posed as to how do we get this going? I mean, the implementation, of course, that's half of the title, implementation and recommendations. Any of you who wants to talk to known or maybe invented by you on the spot, national or international plans for implementation?
Well, maybe I can start. I know in the Netherlands there is a plan for diabetes care, for example, where they made cartoons to simplify choices which can be made, and to have the information at the appropriate level Bruno was just talking about, and start having these discussions. And of course that should be evaluated whether it really leads to better care. I told you about the shared decision making.
And this is mostly about shared decision making, but I think the question was more on person-centered value-based healthcare. How are we going to implement this nationally or even internationally? And shared decision making is a piece of it.
Sure, but I think we should start with the pieces and then and move forward to the larger issues. If we want to do everything at once, we're doomed to fail, I guess. So we'll have different people setting different steps, and then we have to share good examples.
Thomas, you wanted to comment? You raised your...
Yes, sorry. I mean, I agree, obviously there's a lot of different pieces to this puzzle, and that have to be tackled one by one, but I also think there is a great value of having a national plan or having a political mandate, and I think the Netherlands has been an excellent example of that, where that really helps all the players to align and understand that this is the direction of travel. So I think that should absolutely not be underestimated, and I think that there's also a role for the international level, and you need to figure out things, you know, for the European region. What can the EU do? What kind of tools do they have if we're going to standardize outcomes data to be able to measure and benchmark, let's not do it nationally. Let's try to do it internationally for obvious reasons. So you need to see what needs to happen at different levels. But I think certainly as a certain level of political buy-in and engagement, I think is very important.
Yeah, I sort of agree that it would be nice if someone on this call could come up with the grand solution.
The ultimate solution, yes. Yeah, we want it now. We have 5 minutes left for that, Sean.
But I did. No, I wasn't going to offer to do that. But I because I do think there's a lot of component pieces. So I would talk about, I think what ICHOM has been doing and trying to do, is critically important, right? Which is, getting the sort of defining what are the important outcomes to make sure they reflect what patients and people think are important, and then, have those consistently measured. I would say that one of the, real challenges and also an opportunity is that, once we know what is important and learn that from patients and individuals, those outcomes, they're often not going to be available in traditional electronic data sources, real world data, electronic health records, et cetera. So I think that one piece of the solution is, really pushing on this whole digital endpoint to make sure that, there are things that are readily measured and consistently measured in the process of care that actually reflect what we've learned from patients are most important, and make sure that that data is broadly accessible. So, I would just focus on, let's make sure we get high quality, consistent data on the outcomes that matter to people in electronic real world data sources so we can start to work with that.
Excellent, true, totally true. While you're still on the line, or you muted, someone asked you about the pressure on HTA for early approval of interventions. That's a big struggle, I think, because we tend to approve medicines and interventions much too early, and then it's really hard to get them out of practice. It's easier to implement stuff than to de-implement. Do you have a
I think that comment was a bit of, suggesting that there was an opportunity in the case of these products that are given these conditional approvals and conditioned on collecting additional data, that there's an opportunity there to make sure that that additional data is particularly focused on the outcomes that we learn are most important to individuals. But again, for that to work, I think it kind of goes back to how are we going to efficiently collect the data that reflects what's most important to patients, which kind of goes back to my previous comment. But yeah.
Okay, true. I saw someone on mute. Were you going to comment, Willem-Jan, or was it still?
I think I can comment. I was chair of an ICHOM working group in my profession. And coming back to the small steps, when I wanted to implement it in the Netherlands, we had to agree with councils within the profession, patient participation, hospital participation, politics involved. So it takes time, and it helps to set the future to scope of your aim, and then set small steps to reach it, to be able to ask it from patients, to get the knowledge. It's a long time. It takes a long time.
Yeah.
It's a process.
May I add, Anne?
Sure.
So Willem-Jan previously meant the, how do you say this in English? The counting the steps, your steps every day. 10,000 steps we should walk every day. That's good for our health. So somewhere this app, many people use it every day. And at the coffee machine, we discuss how many steps you have made. So somewhere in the past 5 or 6 years, this new app entered our life. And in the Netherlands, we have other examples like Ommetje to do your walking, and you are in competition with other individuals or groups. And maybe this is, I remember the good example about prompts, collecting prompts in Kenya, where the use of mobile phones went up in the past years, and it's proved to be a good way to collect PROM data via the mobile phone.
Yeah.
So maybe in the coming years we should try to find, and then not found out by the system, but found out from the patient side or patient group's side. Find something like that. That we find some, like Sean mentioned, some indicators, some selection of data which you can easily measure or automatically add to your mobile phone via an app. Maybe that should be, then you're becoming more aware as a citizen or even as a patient that it is useful to collect your data, and then at the time that you are in the room with the doctor, then you will have maybe a less hesitation to ask questions when you have already collected data of your own.
Yeah, that's a really important one, and that's what Nicole speaker spoke to also in the Tuesday panel on low and middle income countries, where there's a huge mobile phone coverage and not so much electronic medical records, etc., where that might be very useful. One warning I would say, Marlene Kunneman, one of our researchers here, always warns against the burden on the patient. We also have to make sure that we don't overburden patients, because some particularly chronic disease patients, diabetes, kidney disease,
yeah,
they have a whole life managing their disease. So if we add on top of that, we add and we add and we add, there it's going to be even harder. So that's one thing we really have to take account of, that we don't overburden patients if we want to engage them.